Okay, perfect. And I'm going live and okay. So good afternoon, everyone, and welcome to another DRM hosted webinar. We hope you enjoy and learn lots during this next hour with us. Just before we start, some housekeeping rules. Please note that this webinar is being recorded and it will also be uploaded to our YouTube channel for those unable to attend today but still keen to learn. As you may have heard, it is also being live streamed on our DRM Facebook page at the moment. As such, we do take your participation today as consent to be recorded, and please don't stop the recording if you are able. Second, since it is only an hour long and we know that Prof has a lot to get through, can you please make sure that you are muted and keep your video off during the presentation to minimize distractions? If you have a question or a comment, please raise your hand or ask it in the chat box, and we'll respond to it as soon as we are able or at the end of the presentation. Thank you, Fatima Peters, for organizing this webinar and all your technical support this afternoon, and all other DRM team members, especially our DRM chair, Dr. Shafika Dakrat, for your attendance today. Now that housekeeping is aside, I'm really excited to introduce our presenter today, Professor Ashraf Kagee. Professor Kagee received his PhD in counseling psychology from the Ball State University. This was followed by a postdoctoral fellowship in the Department of Psychiatry at the University of Pennsylvania School of Medicine and a master's degree in public health from UCT. His work is broadly located at the nexus of psychology and public health and is specifically focused on mental health among those living with HIV and psychological and structural factors influencing adherence to antiretroviral therapy. He teaches research methods and cognitive psychotherapy in the Department of Psychology at Stellenbosch University. His other interests include stress and trauma, mental health and chronic illness, and evidence-based practice and scientific thinking in psychology. If you go onto YouTube, you can also find a recent interview with him speaking about PTSD in these times of COVID. So please have a listen to that after this webinar. He has also published in a wide variety of journals, including Global Public Health, Social Science and Medicine, The Lancet, and Transcultural Psychiatry. Prof. Kagee has become quite the best-selling author as well, known for Kagee's Journey, for which he won a European Union Literary Award, and most recently his title By the Fading Light, which was part of the exclusive books recommended list for May 2021. Today, Prof's presentation will introduce us to mixed methods of psychology. Mixed methodology is a process in which researchers integrate quantitative and qualitative methods of data collection to understand a research problem. Prof will be illustrating to us that in certain instances, a combination of qualitative and quantitative methods provides a better understanding of the research problem or issue rather than either one approach on its own. He will also be providing us some examples from his own body of research in which a mixed methods approach has yielded novel insights and understanding. Thank you so much, Prof, for today's webinar. We're looking forward to it.
Okay, thank you very much for that introduction. I'm very pleased to be here and to be speaking to this group about research methods and about mixed methodology. It is really unfortunate that we can't see each other in person because I find being in the same room as people much more rewarding than looking at a computer screen. But here we are under the present circumstances, and let us do the best that we can. If anybody has any questions as I go along, you're welcome to put your hand up or ask a question if you wish. I'll try to, I've prepared my remarks, but if the conversation goes in another direction, that's perfectly fine with me. So I'm going to be talking about the relationship between qualitative research methods and quantitative research methods. And I'm going to try to show how we can use a combination of these two approaches to yield information, to yield data that can be optimally helpful in answering especially difficult research questions that may come about. And of course, because I work in the Department of Psychology, the examples that I'll be talking about are psychological examples. Can everybody see my slides? Can I just get an indication that my slides are visible?
Yes, Prof.
Yes.
Thank you.
Okay, brilliant. All right. So when we talk about mixed methods, we talk about combining qualitative and quantitative research, and it goes back to the 50s where Campbell and Fisk spoke about multi-trait, multi-method approaches. I'm sure the names Campbell and Fisk are familiar to people who study methodology. And other names for mixed methods research include mixed methodology, methodological triangulation, combined research, and multi-method research. So what we're talking about here is really a combination of different approaches to research methods to be able to answer certain questions. And how do we know what is a mixed method study? Well, a mixed method study will have at least one qualitative method and one quantitative method. If it doesn't have at least one qualitative method and at least one quantitative method, well, then it's not a mixed method study. And another way of thinking about it is when researchers integrate quantitative methods of data collection and analysis with qualitative methods of data collection and analysis to understand a research problem. So this is what we refer to when we talk about mixed methodology. So the purpose is that the combination of these two approaches will provide a better understanding of a research problem or issue than either one or the other alone. So what we're referring here to is a synergy of methodological approaches to yield insights and understanding and data that go beyond what one or the other can potentially provide. Now, there's been a lot written about mixed methodology over the years, and these are some books. The main author I want to recommend is John Cresswell. He's done lots of wonderful work in mixed methodology and has written several very important textbooks on this particular approach to research methods. So my recommendation after this presentation, if you feel that you want to learn more about it, is to maybe read a couple of Cresswell's books and also books by other authors. So there's a range of reasons for using mixed methodology. In my own work, for example, I've developed measures, instruments to for use using a mixed methodological approach. It helps to stimulate new research questions and ideas. You can clarify results using a mixed methods approach. You can triangulate data to examine inconsistency in findings, and the two approaches complement each other to address overlapping components of a particular phenomenon that you wish to investigate. Triangulation is a very important aspect where you bring together different strands of data to corroborate findings, to understand findings a bit better. Some methodological approaches are not optimal, but they are important and useful. They might be weak, and so you want to draw on the strengths of each approach to be able to yield some kind of complementarity. You want to bring together a more comprehensive account of a study topic to be able to arrive at some completeness. And then we often use mixed methods, for example, quantitative research to provide an account of structures in social life, and qualitative research to provide a sense of the process. So structure and process, we bring these together to yield insights and understandings that would not be possible with a single approach. It is often the case that we use different approaches to answer different research questions. And this is important to keep in mind. I often tell my students, what is the research question that you're wishing to answer? Formulate the research question in a way that is answerable. You need an answerable research question, and then let us develop the methodological approach that is going to be best suited to answer the question. So sometimes a student might say to me, I want to do qualitative research. Well, fine, but that's putting the cart before the horse. Let us first identify the research question, and then let us identify the optimal methodological approach to answer that research question. We can use mixed methods to explain data, to use one method to help explain the findings that is generated by another approach. Sometimes we get unexpected results, and so we want to understand surprising results from one method by employing another method. Let me just say something about being surprised by your findings. I think this is a very important thing. You must allow yourself the possibility that you could arrive at findings that are unexpected, that are surprising, that you don't necessarily think would be the case. And this is the purpose of doing research. You want to be able to identify what the data say and how they can help you understand something, rather than to know the answer before the time and then design a study so that you can find the answer that you're looking for. That is not the correct approach. The correct approach is to ask the question, design the study, and allow yourself to be surprised by the findings if the findings are indeed surprising. Mixed methods also provide a contextual understanding from qualitative research with broad relationships or generalizable results from quantitative research. You can illustrate data, to use qualitative data to illustrate quantitative results, and to develop results that are more useful to practitioners and others who are going to take up your research findings and implement these findings in society in the work that they do. So there are a whole range of reasons why mixed methods is useful, can be approached in a combination. And what we want to do is capitalize on the strengths of both qualitative research and quantitative research. We essentially want to take the best of both worlds. So I'm sure I don't need to tell you how to recognize the difference between qualitative research and quantitative research. One of the important things, though, to keep in mind in qualitative research, in a qualitative, you're not really trying to make any inference. You're not trying to say, here's my data, I'm going to take these data and generalize to a population. That is not what you do in qualitative research. In qualitative research, you're really concerned with a thick description of what is going on with your research participants without any notion of inference. You want to be able to describe and understand what goes on with these participants whom you might interview, whom you might observe. You might use documents, you might use audiovisual materials in order to understand your research participants. In quantitative research, the purpose is generally to say, well, here's a population, I've recruited my sample from this population with the assumption that the sample is going to be as representative as possible. And I'm studying the sample with a view to making an inference from the sample to the population. I want to make statements from these people that I've recruited into my study to the population. Inference, generalizability. The more representative the sample is of the population, the better, the more accurately you can make inference about the population. So quantitative research is about inference. Qualitative research is not about inference. It's about understanding the people that you are studying in your research study. So when we speak about mixed methods, we can compare the two results and see what we find. We can use qualitative research to help explain our quantitative findings. We can explore using qualitative research and then generalize findings to a large population using a quantitative study. The question is, how do the two meet? Where do they join? And this is what we're going to be talking about. Sometimes we might want to develop an instrument because none are available or useful with existing research in the journals. And sometimes we want to augment and experiment with qualitative data. We want to understand more deeply the narratives, the experiences, the meanings that people make when we find certain results from our quantitative study. Triangulation, this is a very important point. What we try to do is validate data through cross-verification from two sources or more than two sources. And so what we're really trying to do is combine several research methods in the study of the same phenomenon. This is what we seek to do. Now, I do want to say that I would not recommend a mixed methodological approach for a novice, for a beginner. I would suggest that you get some experience doing quantitative research and you get some experience doing qualitative research. And once you've completed a couple of studies using those particular approaches, to then consider the application of mixed methodological approaches in the context of a research question that requires such an approach. You don't first say, I'm going to do mixed methods, let's find a research question. That is not the way to go. First, identify the research question and then see on what basis do we now decide on a appropriate design for the study. Usually, mixed methods research involves teams of researchers, and some researchers might be very adept at doing quantitative research, and other members of the team might be more adept at doing qualitative research, and so they complement each other. But it's really important for everybody to understand what's going on. So the message at this point is, if you don't know one or the other, get some experience, get some training, get some first-hand experience of conducting research using these two approaches. Now, you get the purists, the purists who study philosophy and epistemology, and they say to you, well, these things come from completely different epistemological traditions and different paradigms, and they shouldn't be mixed. Mixed methodologists actually don't try to reconcile paradigms and epistemology. That is not of interest. Of interest is what is going to be most useful under the circumstances in order to answer a specific research question. So you can get yourself bogged down with Foucault and critical psychology and paradigms and positivism and evidence-based treatments and all that stuff. And that's fine. That is an upstream conversation. We are downstream from that conversation. We are talking about what are we going to do when we have a complicated research question and we're trying to answer it using a range of different approaches. So when you design a study, there are a few things to consider. I've just written down 3 things here: the timing, the sequence of the studies, qualitative, quantitative, and maybe another qualitative piece. Priority, which one is going to be favored over the other. And then synthesis, how are the data being merged? This is an important thing, because a mixed method study is not 2 separate studies that have nothing to do with each other. They must have something to do with each other. They must be connected in an important way. And that connection, that synthesis, that merging of the 2 approaches is what is going to give you your unique insight and understanding and the special findings that would not be obtainable if you use only one or the other methodological approach. Okay, before I go on to talk about an example, let me pause for questions before I talk about a particular example. Are there any questions so far? Fatima, no questions?
Yeah, Prof, there's no questions at the moment.
Okay, I hope people aren't falling asleep. I'm trying to be as energetic as possible. But let me talk about a study that I was involved in. And in the study, we used a mixed methodological approach. So I study mental health conditions among people living with HIV, and I study especially mood disturbance. And one of the issues is, how is depression experienced by people living with HIV? And the reason we wanted to study this, because mood disturbance, depressed mood, is associated with poor adherence to antiretroviral treatment. And if people have depressed mood, they are less likely to take their medication. If they don't take their medication, they get sick, they have to go to hospital, they can die. So if we study depression and understand it, this is a very useful thing in helping us think about ways in which we can intervene. So the question was, what is the experience of people who have depression and who are also living with HIV? So what we did was, we recruited people into the study, and this is from an infectious disease clinic in Khayelitsha in Cape Town, and everybody had major depressive disorder. So let me talk about the procedures first. We recruited participants through routine screening in the clinic, in the infectious disease clinic of a major hospital, and then we administered the CESD. I've got a picture here. What is it? The Center for Epidemiological Studies Depression Scale. That is a picture of the scale there, and you can see, I'll get back to it in a second. And we administered this instrument to participants, and those people who scored above the commonly used cut point of 16 on the CSD, we screened them. Some people scored above the cut point, and we recruited them and we gave them the mini international neuropsychiatric interview. Okay. And then we identified a group of people who met the criteria for major depressive disorder. One person was excluded because they didn't meet the diagnostic criteria. So everybody who screened positive for depression on the CESD were given the mini, mini international neuropsychiatric interview. They met the diagnostic criteria. Okay, so then we took these 14 people and we did qualitative interviews. So you can see in this part, there's a quantitative component where they completed the CSD, we counted up their scores, and they were then given the mini, and they were identified as having major depression. And those people who had major depressive disorder were then asked to participate in qualitative interviews. And we said to them, can you describe this experience of depression? What does being depressed mean to you? What thoughts do you have when you're feeling depressed? What is this experience like? What is the meaning that you make out of your life at the moment, considering that you have depressed mood? One of the things is in the Xhosa language, there's no actual word for depression. So feeling sad and tired for a long time, that was the term used to refer to the condition of depression. What we did then, we took the data, the qualitative data, and transcribed it. We recorded it using a recorder and transcribed it and entered it into Atlas TI, which is a very useful program that helps with the analysis of textual data, and analyze this for themes, right? We wanted to identify themes that could tell us more about participants' experiences of depression. And these were some of the terms that we used, that we learned. But there were certain things that came out, and these are some quotations. I didn't want to listen. I know at the end of the time I have to listen to that child, so I feel guilty, but it's too late now because I chased him away. I was so unhappy, not having a hope that I'm going to be all right. Sometimes I was feeling that I could get someone to kill me for not to stay like this. So you can see people's experiences are very severe. These are people in a great deal of psychological distress and pain. Wanted to sleep the whole day. My head is breaking in two. I'm lazy with sex. This is a loss of libido. Thinking. Depression is very wrong because you think negative things. You think you're lonely, you don't feel like doing things that you used to do. So the symptoms range from being affective symptoms to cognitive symptoms, behavioral symptoms, and also unique idioms of distress, not being oneself. This is a unique idiom of distress that is not captured in a lot of the existing measures, the existing psychometric instruments, like the CSD or the Beck Depression Inventory or the Hopkins Symptom Checklist. These unique idioms of distress are not captured there. So we learned this. We learned people's subjective experience of depression not being oneself, which referred to the awareness of something within the person that negatively changed. Thinking too much. This was related to negative perceptions of the self, the environment, and the future. Thinking too much. Thinking too much is not in the DSM. That is not a diagnostic symptom that is listed in the Diagnostic and Statistical Manual for Mental Disorders. We also understood that in the context of a busy infectious disease clinic, patients are less likely to share their affective and cognitive and behavioral symptoms with the HIV clinic staff, with the nurses, unless you actually ask them. And if you've got lots and lots of patients attending the infectious disease clinic, the time to actually ask people about these symptoms is simply not there. So we took these data and made up a scale. It's called the South African Depression Scale. And there were local idioms of distress in the scale: thinking too much, carrying a lot of weight on my shoulders, pain in my heart. These are the local idioms of distress. And then there are also traditional symptoms of distress that you do find in existing psychometric instruments and in the DSM. Sadness, depression, depressed mood, sleep disturbance, anhedonia. Anhedonia refers to loss of interest or pleasure in activities that the person formerly found interesting or pleasurable. The idea of isinkala, a deep sorrow, which was added from consultation with the mental health providers who were working at the clinic. Okay, so this is the scale that was then developed, and we did a whole bunch of psychometric things with the scale, a receiver operating characteristic curve analysis to identify the optimal cut point on the South African Depression Scale that would discriminate between those people who are probable cases of major depressive disorder and those people who are probable non-cases of major depressive disorder. That was the purpose of the study. So just to recap, we screened everybody in the clinic using the CSD, followed them up with the mini. Those who met the diagnostic criteria underwent qualitative interviews. We took the qualitative data and we created a new scale, the South African Depression Scale, and we then did a whole bunch of psychometric analysis on the scale. All right, let me pause there briefly for questions. That is an example of a mixed method study. You can see it was sequential. Quantitative, qualitative, quantitative.
Okay, so Prof, we have two questions. The first question is, how would you phrase the research question?
How would I phrase the research question? Okay, so there are a couple of research questions. One is, what is the experience of persons living with HIV who meet the diagnostic criteria for depression, for major depressive disorder? What is the experience of their of living with depression? That is the one thing. That is the first question. The second question is, can a culturally relevant screening instrument be developed for use among persons receiving antiretroviral treatment? Is that helpful?
Yes, it's helpful, but if you were to help a student to understand how to develop a research question for a mixed methods study, what would your recommendation be?
So my recommendation is that you don't develop the question for the method. You develop the method for the question. So you first ask the question, and maybe the question can be, can we develop a psychometric instrument to assess mood disturbance that is culturally and contextually relevant for South Africans receiving antiretroviral treatment? It's kind of a long-winded question, but it's a very specific question. And then you'll have a couple of sub-questions or sub-aims underneath that, which is what we spoke about. And then you design the mixed method approach given the question. But I'm not going to tell you that you need to design the question to fit the method. That is putting the cart before the horse.
Completely agree with you there, Prof. So, would you have, in the sub-questions for the main aim of the study, do you have to identify a qualitative question and a quantitative question?
So again, the approach would be, here's the problem, here's the research problem, here's the aims and objectives, here's what they are. What design do we need to be able to answer these questions, to be able to achieve these aims and objectives, to be able to obtain the relevant data that are going to meet these aims? And so you will have these sub-aims and objectives, and then design the components of the study that are going to fit with the questions.
We have another question. What method was used to merge the results of the qualitative and the quantitative sections of the study?
So recall, what we first did was we screened people to identify, to separate out who met the criteria for depression and who didn't, right? And we then selected those people who met the criteria, who met the diagnostic criteria for depression, and then we sifted them out. And then we did the qualitative study with those people only. So that's already emerging, not emerging, but the synthesis of these two approaches. You use the one approach to identify people who are eligible for the second component of the study. And then you use the qualitative data to then arrive at further quantitative data that are going to be useful in answering the question. I see Mr. Daniel Letzalo. Do you have a question?
I don't. I just joined. Sorry.
Okay. Fatima, should I continue?
Yes, Prof, please continue. Daniel, apologies, but may you please turn off your video?
All right, let me talk about another study that I was involved with and in fact led. And so this study has to do with structural barriers to adherence to antiretroviral treatment. And this is in the context of a large number of people in South Africa living with HIV and needing to be on ARVs, antiretroviral treatment. You can give people their medication, but we find that a lot of people don't actually take their medication. So I understand non-adherence at two levels. One is clinic attendance, people actually going to the clinic, going to see the nurse, obtaining their medicine. And then the other level is still taking, actually medicine. That's two levels of adherence. That's the way I think about it. And low levels of adherence is a big problem. It increases vital load. The disease progresses much more rapidly. The person is vulnerable to opportunistic infections. They need to go to hospital. The recovery time is slower. They have to fall out of work because of illness. They can die. There's a whole range of reasons why taking medication antiretroviral treatment is really, really, really important, but a lot of people don't. So here are some of the personal barriers that the literature talks about. Health literacy, people don't understand. Poor social support, mental health problems, as we discussed, fear of disclosure, substance abuse. People are suspicious of treatment. It might be too complicated. They don't like the side effects, a whole range of things. So I wanted to understand more about the structural barriers to adherence, the structural barriers that these are social, economic, institutional, political, cultural factors that make up the social structures that influence behavior. So what I did was I interviewed patients and nurses and doctors, and also patient advocates. Patient advocates are people who are in the community and work with NGOs to encourage patients to go and seek treatment and get treatment. And they maybe walk to the clinic with the patient, they sit in the waiting room, they provide support. The picture you see there, though, is not of real participants, and I obviously wouldn't put pictures of real participants on a presentation. Okay, so we did a qualitative study. We spoke to a small number of people actually at this hospital, at the infectious disease clinic. I also worked with an NGO that provides support to people living with HIV. And we did focus groups, and we actually got some saturated data, and we transcribed and analyzed these data. And there were a whole range of things, structural things. Stigma was one of the important things. And I'll talk about some of these things. You can just take a look at the slide. I'll talk about them in a little bit more detail. Stigma was a really important structural problem. I don't tell people because they will make it a problem. Tomorrow the story will spread in every direction. That's why I never tell them. The community is small. So people wanted privacy. They didn't know where to keep their medicine in their houses because they were concerned about being discovered by other people. And if you live under overcrowded conditions with lots of people in the house, well, it's difficult to actually store medicine. So a lot of people rather don't want to bring the medicine into the house. And if you don't have access to the medicine, you don't take the medicine. It's a problem. This was a very interesting thing, disability grants. And there were a few patient advocates that told us that people deliberately didn't take their medication because they wanted to keep their CD4 counts low to retain their eligibility for a grant, for a disability grant, and the doctors couldn't approve these benefits if the patient didn't meet the criteria. It occurred in a small number of people, and in no way is this a generalizable thing, but they did tell us this. And when the doctor didn't want to sign the form, it was a rupture to the doctor-patient relationship. And some people didn't come back as a consequence of that. These are some quotations they told us. The CD4 count drops, then they can requalify for the grant. Sometimes they use it as blackmail to say that if you don't give it to me, I'm going to stop my medication. So this doctor said it's a huge issue because patients initially aren't often aware of the fact that it's a temporary grant. Then relatedly are relationships with clinic staff. Patients don't want to go to a particular clinic because the staff is rude to them. The staff get short with patients, they raise their voices, they shout at them. The staff is sometimes hostile. Lack of privacy. If you're doing counseling, adherence counseling, people talk about their private lives, their personal lives. They don't want another counseling session going on in the same room. Yet this is a structural problem. There weren't enough rooms in the infectious disease clinic where they could experience privacy and confidentiality. So a lot of people just didn't go because they didn't want other people hearing their stories. Transport costs, quite expensive. Long waiting times at clinics, and especially these were parents who came with their children, and they have to wait long hours in the clinic to be seen, to get a few minutes with the doctor or the nurse. Food insecurity, another structural problem. because people didn't want to take their medicine on an empty stomach, made them feel bad. And then substance abuse. So substance abuse itself is not necessarily a structural problem, but the absence of substance abuse treatment facilities, that is a structural problem. And so if people come to the clinic inebriated, then it creates a rupture in the nurse-patient relationship. Then there were other things like, migration, people going from the Western Cape to the Eastern Cape, and then they don't collect their medicine when they're supposed to. But also the role of charismatic churches, because we found that that some of the charismatic church leaders told their congregants, you mustn't take your medicine, because if you take your medicine, it means you don't have faith in God. And faith in God is what is going to help you with HIV. We found this, believe it or not. And interestingly, what is currently going on with the uptake of the COVID vaccine, there's evidence now that some of the charismatic churches are also playing a role in dissuading people from accepting a COVID vaccine. That's another matter. Anyway, qualitative data. So now we are faced with the need to look at to what extent is this generalizable. Qualitative data cannot be generalized. You're focused on the participants that are recruited into your study. So we made up 2 scales. Remember the 2: barriers to attendance, clinic attendance, and barriers to medication taking. And we created these stems. I do not attend my clinic appointments because that was the stem for the one, and I do not take my antiretroviral treatment pills because, and that was the scale for, the stem for the other scale. And then we took the qualitative data and we created items. We constructed items for these 2 scales, and there's a process that you go through where you take away the redundant items and the lengthy items and the double-barreled items and the ambiguous items, and you make sure it's at an accepted reading level. And we then recruited up almost 300 people who were ARV users with the help of this NGO. And so there were these 2 scales. The structural barriers to clinic attendance scale, that was 12 items, and the structural barriers to medication scale, that was 13 items. And this is how they looked. We gave it to these 291 people, and we got some data, which we then analyzed. And you can see here, there's some data on the corrected item total correlation, the alpha if item deleted, the mean and the standard deviation of each of these items, right? We then did principal components analysis and tried to understand the underlying factor structure of these 2 scales. This is the structural barriers to clinic attendance, and this is the next scale, the structural barriers to medication taking. We don't have time for me to go through each of the individual items now, but just so you can see that there are quantitative data associated with these instruments. And these are the results of the factor analysis. These are the factor loadings that you can see for the structural barriers to clinic attendance and the structural barriers to medication taking. And this is Pearson's R for the scores between the 2 scales. And obviously they're going to be correlated. The question is how correlated, because you can't be taking your medicine if you're not attending the clinic. So they have to be correlated. And this was verification of that fact. So this was the paper that we developed on the basis of these data. My colleague, Dr. Bronwyn-Coetzee, who this was data from her master's thesis actually that we used for the studies. So the next phase of this work was with a larger group of participants in a case control study. And it was really a test of the IMB model, the information, motivation, behavioral skills model of adherence to antiretroviral treatment. So we included these two scales. And we identified those people who were adherent and those people who were not adherent. And we recruited a sample of people. And until we got 300 adherent and 300 non-adherent patients, the non-adherent patients were less common, so we had to oversample that group in order to make a proper comparison. And these are the data of that particular study, where you can see there was a significant difference on the scores, in the scores of the two scales, the two top ones, structural barriers to clinic adherence and structural barriers to medicine taking, between those patients who were adherent and non-adherent. And then the other two scales were motivation and behavioral scores. Those were also adherent, as you can see there. And this is the results of the logistic regression, where you can see that the structural barriers to clinic attendance and medication taking, those emerged as significant. Also behavioral skills, and also interesting, gender. Men were less likely to be adherent than women. Interesting. And the reason for that, I think, and I don't have data, but I'm speculating, is that the clinic, the infectious disease clinic, the hospital, that entire culture is feminized. It's a place where women go. The nurses are women. Most of the patients are women. And my feeling is that a lot of men don't feel comfortable going to clinics, and therefore don't collect their medicine and don't take their medication. Anyway, we found that structural barriers were associated with poor adherence, especially food security. Quite a lot of people reported not having food with which to take their antiretroviral treatment. Okay, I'm going to stop there, and you can see that this is an example of a mixed methods study where we did qualitative interviews, focus groups, obtained qualitative data, created a scale, administered the scale to a larger sample of people, did exploratory factor analysis and item analysis, and then published the scale. The scale was then used in a subsequent study to identify reasons for non-adherence. So those are two examples of mixed methods research.
Okay, so Prof, there's a question. Is the tool that was developed in use in South Africa by practitioners?
Tell me the question again, please.
The person wants to know if the tool that was developed is being used by practitioners.
Yeah, so what we wanted to do is make a brief instrument available that can be used by practitioners in a busy clinic. And with the second quantitative study, the case control study, what we wanted to do was make it available to practitioners. So it is available. The province has to make recommendations to the clinicians at the clinic about whether they want to actually use the scale. So it is certainly available. I don't know the extent to which it's used. What is important, though, is the fact that clinicians need to attend to structural factors when thinking about the likelihood of people being adherent to their medication. Because it's not good enough to say you now receive an HIV positive diagnosis. Here's your antiretroviral treatment, make sure you take it. That is not good enough. What we do need, and what does exist to some extent in many of the clinics, is adherence counseling, and adherence counseling needs to consider some of the structural factors in addition to the personal factors that stand in the way of optimal adherence to ARVs. Any other questions?
The student wants to know, the person wants to know if you have to develop a questionnaire as you have done in the study. Is it necessary for students doing a mixed method study to develop a scale as you had done in the study?
No, it's not necessary to develop a scale. In the previous example I gave, where we used the CESD, the Center for Epidemiological Studies Depression Scale, to screen people, to identify those participants, those people who actually have depressed mood, and then do a diagnostic interview, and then interview those people qualitatively to understand their lived experience of depression. That is a mixed method study. There's no scale that needs to be developed. You can take it to another level and develop a scale like the South African depression scale, which we did do, but that's not necessary. The first two components of that study is perfectly fine as a mixed method study.
Okay. The other question is it possible or should a student use an international scale and a local scale if the purpose of the research is to compare international studies with local studies?
I think one needs to consider carefully the relevance and applicability of international scales in the local context. So, for example, if there's evidence that an international scale, I mean, I've used the Beck Depression Inventory many times, but I've stopped using it. It did work. It did give me useful data and useful information, but the Beck Depression Inventory focuses a lot on the cognitive symptoms of depression and not so much on the affective symptoms of depression. And it certainly doesn't say anything about the local idioms of distress, like thinking too much, or my head is broken in two, or my heart is sore, or those kinds of local idioms that people talk about. So I've stopped using it for those reasons. The CESD, which is also an internationally used scale, is much more useful because it incorporates a whole range of those symptoms, but it still doesn't incorporate the local idioms of distress. So it depends on your research question. It depends on how rich you want your data to be and how textured you want your data to be. If all you're doing is wanting to screen out people who are non-depressed, so you can take the depressed people and give them treatment, the CESD is probably going to be useful. But we've now published the South African Depression Scale, and we'd like people to use it and to tell us if it's a useful thing to do. And sometimes you need both to be able to make comparisons. Any other questions?
There is another question, but I'm not.
Where would I find the questions? I can't see them myself.
Prof, if you're using a computer, right at the top, there's a red button, then a left arrow, then the sound where you switch your sound on and off, then the video, then 3 dots,
yes.
Then a big and a small square, a hand and a face, and next door to that is a little circle with lines, and if you click on that, you'll see the questions.
Yeah,
but there's another question by this. Okay, maybe it's because setting situation. We have 5 minutes left, and there's a question by a participant that's attending today. I'm not quite clear on the question, but it reads as follows: would it be feasible to do mixed method and focus primarily on qualitative analysis and only use frequency tables, show or highlight significant information quantitatively? I'm not quite sure, but maybe you can interpret the question.
Right. So the question is, can you only use frequency tables? And I think it depends on the research question. I mean, frequency tables are not going to allow you to make any kind of proper inference. Really, you need P levels, probability levels, to be able to say if there are significant differences between two groups or whatever the case may be. So it'll give you descriptive data, but probably not inferential data.
Okay, so we have a few 2-3 minutes left. I do not see any other questions in the chat box. We can wait a few minutes more if there is anyone else that would like to ask any questions.
Okay, while we're waiting,
Yes,
maybe I should say, you know, if you want to get experience with this kind of thing, my advice is to become quite proficient as a quantitative researcher and also proficient as a qualitative researcher, and to get experience doing both forms of research, and not to box yourself in and say, oh, I'm only a qualitative researcher, I don't do quantitative studies, or vice versa. I don't think that's helpful. These days, methodologists need to have a broad range of skills. You need a broad repertoire of skills to be able to identify answerable research questions and run with them and answer them, and design studies that are going to be helpful and useful. So developing skills in both qualitative and quantitative research, I think, is a good thing. And then get mentorship and supervision in doing mixed methods research. I don't expect a novice researcher, a beginning researcher, to be able to do a mixed method study at this particular point in their lives, of their careers. So get the experience, get the skills, and learn data analysis skills. Learn SPSS, learn R if you have access to training where you can learn R. Learn Atlas TI or InVivo or Nudist or whatever the case may be. And understand what they can do. I do want to say these qualitative data analysis programs like Atlas, I worry about people actually understanding what they do. They don't actually analyze the data for you. They assist with the analysis. They help you organize your data. But the analysis actually gets done by yourself using your brain in order to understand your data. So a computer program is not a shortcut to data analysis. You really need to understand and read and reread your qualitative data in order to understand it, to become familiar with it, so that you can then apply Atlas and those other programs. When I teach qualitative methods to my honors students, for example, we don't use any program. We use a highlighter. I don't know if you can see this, and we use a pair of scissors, and we use newsprint, and we use Prit, and we give them text, and they analyze it using these instruments and these materials that I provide to them. And on that basis, they conduct the analysis and the coding and identify themes. Only later do they actually get trained to use the computer program. So I'm much more in favor of people learning the basics without the fancy gadgetry, and then we can teach them the programming later on. It's in the same way that you want to teach kids how to add and subtract and divide before you give them a calculator.
Excuse me, Prof. Just before we conclude, the DRM and SASA is requesting that participants attending the webinar please complete the short evaluation form. We would like to identify if there are any webinars that people would like us to work towards for next year, and also if there's anything that we can improve on. So people must please complete the Google Forms document that the link is in the chat box. And Prof, really excellent remark with regard to the use of Atlas TI and the way in which one should go about doing the analysis. I think that sometimes we live in such a technology-driven society that we forget that we must actually use our brains to use the tools better. So yeah, it's 1 o'clock now, and we are concluding the presentation. We have one last question. You may go ahead, but we might end up cutting out because the time is actually concluded. Kebope, you may go ahead.
Yes, thank find the recorded version of the presentation?
May you please repeat?
Where can we find the recorded version of the presentation?
Oh, the presentation has been live streamed onto Facebook DRM webpage, CISA DRM webpage. Additionally, we will save the presentation and upload it onto the CISA DRM YouTube channel. I'll put it in the chat box in case I was not clear. Okay, so Prof Shukran, thank you so much for the presentation. It was enlightening, and I think the discussion of the actual research and how it was conducted or illuminated the ways in which we can go about the presentation. I'm not sure, Pakiza, are you still here?
I'm still here. Sorry, I've just been very quiet so that I don't affect the Facebook live stream. But thank you, Prof, for all of your wonderful insights this hour. And yes, everybody, you can always go onto our Facebook page to rewatch or go onto YouTube. But yes, Prof, we're making you famous across all of these social media platforms.
Okay, thank you for your time, and it was very nice to be with you.
Keep well, everybody. Have a wonderful afternoon. Keep safe. See you next week.
Bye.
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 Fatima? Fatima?